Welcome everyone. My name is Violeta Astratinei and I am PhD biologist and a patient advocate at Melanoma Patient Network Europe. After losing my sister to melanoma in 2014, I founded Melanoma Romania Association and started my work as patient advocate and scientific advisor at Melanoma Foundation in Netherlands. I have the pleasure today to introduce Dr. Teresa Amaral, a medical doctor specialist in oncology at Tübingen Medical University from Germany. We will discuss today a selection of interesting studies at ESMO in Madrid last October. So welcome, Teresa. Happy to have you here, and the floor is yours.
Thank you so much, Violeta, for the kind introduction, and thank you also to the International Cancer Foundation for the invitation to be here today and to discuss these interesting studies and works that have been presented and discussed at ESMO. So I think we can start with the discussion, and I will just show you my disclosures that I don't think have anything to do or do not influence my presentation today in the discussion, but here they are in case you want to read them. So this is also a disclaimer that we need to have during the presentation. So if you want to stop the video and read it carefully, please do so. I will skip to the next one so that we can start to discuss the science. So the first abstract or the first presentation that we chose to discuss today was a trial that investigated a specific treatment that is called lifileucel tumor-infiltrating lymphocytes cell therapy, and in a specific subgroup of patients with a melanoma that are patients with mucosal melanoma. And I think you will understand why we chose this specific study in a couple of seconds. So why it is important that we discuss this trial today, and why it is important that we discuss this new treatment, as I said, because most of the patients are excluded from clinical trials. And in particular in this trial, we are looking into patients' outcomes for patients that have already received anti-PD-1. And this is obviously a population that has bad or worse outcomes or worse prognosis. So here you can see, and I think it's very important that we discuss also the type of treatment that the patients received in this trial. So this is not, let's say, an easy treatment, and it's not that easy to give this treatment in all centers that treat patients with melanoma. So you need to understand that this is a little bit complicated from the technical point of view. So the patients receive first lymphodepleting chemotherapy, which means that we use the properties of chemotherapy to actually eliminate or to eliminate the majority of cells, the circulating cells. And then after the patients received this type of treatment, which is chemotherapy, that it's quite known, the patients will receive the study treatment, which is in this case lifileucel infusion. So the way that this treatment is prepared and let's say indeed it is prepared so that we can give it then to the patients must be done in a very specialized centers. So this treatment will not or is not available to all the patients that might need it, but we hope that with the improvement of the techniques that are being used to collect this, to produce this new treatment, that maybe in the future this will be available to other patients and not only in specialized centers, but this is the case right now. So, as I said, patients had been treated before with anti-PD-1 therapy before they have been included in the trial, and then they would receive this sequence of treatment that you can see here. So, as I said, this is a little bit of a difficult treatment to be given. So the number of patients that can be included or that were included was also small. So 12 patients, not a lot of patients, but still mucosal melanoma, it's not as frequent as cutaneous melanoma on one side. And on the other side, patients that are fit enough to be included in this trial are also difficult to find. So this is one of the reasons why the number of patients included was low. And because this is obviously a new treatment being evaluated in this setting, so we need to be a little bit careful. Still, the median overall response rate for these patients in this setting was quite high, I would say 50%. the median duration of response, so the time that the patients are under response and benefiting from the treatment, it's not reached, which means that at this time point, more than 50% of the patients still have a benefit from the treatment. The median progression-free survival was also not reached, which means that more than 50% of the patients at this time point didn't have a progressive disease. And the median overall survival in months was 19.4, which means that in median, in median, the patients survived approximately 20 months when they were included in this trial, which is, I would say, quite impressive considering the type of patients that were included in the trial. So, in conclusion, and I think this is open for discussion, but in conclusion, we have an overall response rate that is approximately 50%. The duration of response, as I said, was not reached. So maybe in the future, this will be a new treatment option for patients with mucosal melanoma, especially for those that do not benefit from PD-1-based immunotherapy. And maybe we could even move it to an earlier phase for patients to benefiting from this treatment in a phase where they are still, let's say, therapy naive. And with that, I pass the stage to Violeta, and we can start the discussion.
Thanks, Teresa. Indeed, good news for mucosal melanoma patients, although as a small group. Now, just for a bit of history, lifileucel is an adoptive cell therapy and what we call in our community TILs, like tumor-infiltrated lymphocyte. And it is interesting to know that we do have TIL therapy approved in metastatic melanoma, but only at national level. So it's in Netherlands and Denmark. And this is an academic TIL produced, if you remember, Teresa, in-house at NKI Amsterdam, you know very well that. And lifileucel described here is a company-sponsored product, so we hope this will be accessible to more patients than actually the TILs, academic TILs, it's at the present. I was looking a bit, I don't have so much to comment about data because it's looking like clean data, is a small group of patients, is not very much to say. We need probably confirmation. But for the future, like you also said, I was looking a little bit to the clinical trial site where the lifileucel ran. I saw also the Tübingen University there, and at least 8 countries in Europe. So for us in melanoma, this is a big hope because lifileucel it's under the FDA revision. And we hope that EMA, the European Medicine Agency, will follow. And having these 8 countries running clinical trials, it's quite promising because the experience is there and we can anticipate maybe more willingness for implementation. What I wanted to ask you, and this is the only question that I have for lifileucel, for this trial, I noticed that previous anti-PD-1 therapy were permitted, but we also know that combination EP with Nivo it's actually used in clinical practice for mucosal melanoma patients with a good response rate. It's somewhere at 30-35%. This is data from real life, I think. So what do you think about the place of lifileucel in clinical practice and in the present guidelines?
Yeah, so that's a very good question, Violet. Thank you very much for asking it. I think at this time point, it's very difficult to see or to say what will be the place for this treatment in the clinical practice and what will be, let's say, the outcome from this treatment when we test it in a bigger population. So if the data are confirmed as they are here, so the data that we saw from these 12 patients I would say that this is a very valid alternative for the treatments that we have so far. As you said, also combined immunotherapy with anti-CTLA-4 and anti-PD-1, because the response rates are quite lower compared to the patients with cutaneous melanoma. So if these data that we see here are confirmed further, I would say this is a valid alternative, maybe even in earlier stages, because when we are seeing patients that have already progressed and under anti-PD-1 treatment, we are kind of selecting patients that might have a worse prognosis and maybe derive less benefit from this treatment. Still, even if they were progressive, as it was included in this trial, they still derive benefit, and the duration of response has not been reached. So it's very, very promising. These data are very, very promising. So I think this treatment definitely has its place, not only in mucosal melanoma, but probably also in cutaneous melanoma. As you said, we are waiting for the approval or the final revision from this treatment with FDA. As you said, I hope that ESMO will follow as well. And in the meantime, for patients that are considered to maybe benefit from this treatment, you pointed out, and I thank you for that, the trials that have this possibility or this treatment available in their center, or the centers that have this trial available, they should be contacted so that the patients can be screened to see if they would fit in the clinical trial, and we can offer to more patients than we have just in our, let's say, our referential area or reference area. So yeah, that is my opinion.
That would be great. Why I raise this aspect is that you might be familiar or not, but this is a national thing at the end. We had with TILs quite a problem when we came to the reimbursement, because in the trial we used the comparison like EP, and then we had like previous anti-PD-1 permitted only. So now the patients, most of the patients that were on combination, as you know, this is common to use now in melanoma, they have no, they are not eligible for the reimbursement. So this is creating a big frustration. So I think it's important, if this is going to be confirmed in another trial, or maybe this will to see what to do in order that also this group, having previously access to ipi/nivo, to have access to lifileucel. But okay, this is something to think in the future, and thank you very much for your answer. And
welcome.
Thank you. I think we can move to the next presentation. Thank you.
Okay. So we'll move to another trial that it's very important also in my view, similar to what we had before from mucosal melanoma, from patients with mucosal melanoma. This area of investigator, or this subgroup of patients, the population of patients, have been systematically excluded from clinical trials that are patients with uveal melanoma. And in this trial that has been presented this year, and we selected for this discussion, a new treatment option has been evaluated, and it's different from immunotherapy. So this is a target therapy. And what the data that have been presented were mostly on clinical efficacy, but also in terms of ctDNA reduction, that we know that is at least important in other tumor entities, such as breast cancer and colorectal cancer. And we expect that this will be also a biomarker in patients with melanoma, specifically in patients with uveal melanoma in this case. So just for you to understand a little bit of the background, but I think we can discuss this as well, Violeta, afterwards. The patients with metastatic uveal melanoma do not have a lot of treatment options. Until very recently, the only treatment option that we had was local treatment in cases the patients had just liver disease, so either surgery, radiotherapy, chemosaturation, and so on. So localized treatment option. And if they had more than liver metastases, we would offer them a chemotherapy. So this was obviously not ideal. We know that driver mutations in GNAQ11 and activated protein synase are very frequent and occur in a significant percentage of patients with metastatic uveal melanoma. And based on these two aspects, these two new treatments, one that is both are oral therapies, so I think this is also important to compare with the other treatment options, what have been tested in this setting. The new treatment option that we have available, I will discuss in the next couple of slides. And in this combination was evaluated. So the combination that we are seeing here was evaluated in first line, but also in pre-treated metastatic uveal melanoma. So basically, the study included 68 patients. They had to have measurable disease per RECIST, so this is normal in all clinical trials. They had to have a good performance status, and then they tested different doses and different escalations of doses in the different cohorts that were evaluated. Basically, the results that we have so far include data from 63 patients. I see a typo here. It's largest metastatic lesion, more than 3 centimeters, and this is important for the stratification and the staging of patients with uveal melanoma. It's 66%, so 2/3. Patients with hepatic and extrahepatic disease, it's also quite high. And why is this important? Because, as I said, in patients with hepatic disease, we can maybe offer them local therapy. Elevated LDH, which is also a prognostic factor, it's also patients with elevated LDH was also present in 60% of the cases. Why did the authors provided this HLA subtype information? Because we have now a new approved therapy for patients with uveal melanoma that is based on this HLA subtype that is called tebentafusp. And tebentafusp is only approved for patients with this specific HLA subtype. Therefore, it was important to see how many patients with this HLA subtype were included in the study so that we can somehow make an indirect comparison between these two treatment options. In terms of results, we had confirmed partial response, so patients that did respond and benefit from the treatment of 30%. It's not let's say it's not as much as we would like to have, but it's still important considering the type of patients that were included. Tumor shrinkage, which means a decrease of the tumor size in 92%, and in patients with first line, 95%. So it seems that patients that receive treatment in first line might derive more benefit, but again, number of patients, it's just 20, so it's not a lot of them. And then we have median progression-free survival that is approximately 7 months, so which means that at 7 months, 50% of the patients didn't have progressive disease. And for patients that had only hepatic disease, median progression-free survival was 11 months. So even for those that we may consider to offer just local treatment, the median progression-free survival from this treatment was 11 months, so a little bit longer than for those that were mentioned before. Another aspect that was also important and discussed was the deep and sustained ctDNA molecular response, which we could see in a waterfall plot that the majority of the patients did indeed had a significant and sustained ctDNA molecular response, which means that the ctDNA was cleared or at least was reduced during the follow-up. And why is this important? We see in other tumor entities that this can be a marker or a potential marker of clinical benefit. So it is important that, or it is at least positive that we see this decrease. What we definitely need to check and to see is if this decrease actually translates in survival benefit in the long term. So these are the slides that I presented during my discussion at ESMO. And here you have the potential other therapies that are available for patients with uveal melanoma. I would like to stress that these are in direct comparison. So these are not head-to-head comparison between the trial, but this is the data that we have. So considering patients that didn't receive first-line treatment, so it's 63 patients in this cohort, compared to patients that were included in one of the trials that investigated nivo plus ipi, which is another treatment options that we have so far, and with only 35 patients. you can appreciate that the patients that have been included are, I would say, quite similar in terms of the population. And the same goes if we look into first-line patients included in this trial and compare them to another trial that evaluated ipi/nivo in first line, and then tebentafusp, the treatment that I just mentioned before, that only included first-line patients. So I just show it here. Again, it's in the indirect comparison to see that the patient population included was not very different. If you look into the response rate, again, this is indirect comparisons, you will see that as expected for target therapy, we have quite a high response rate, which is characteristic from target therapy, so 56%, higher than so 89%, I'm sorry, 89%, so higher than we see in immunotherapy. And this for patients with that were treated in first line, it's 90%, but very similar to the others that were treated in second line or more. And again, very or much lower or much higher compared to what we see in immunotherapy, but this is what we see in other target therapies. The median progression-free survival was also longer compared to tebentafusp, for example, that we know it has not a very high response rate. And then we have only median overall survival from the tebentafusp study and another study and the ipi/nivo studies that I just mentioned before. So we don't have median overall survival from this study. But again, the data that was presented this year at ESMO showed a median overall survival for patients treated with tebentafusp of almost 2 years. So despite the benefit not being very high in terms of response rate, the overall survival benefit seems to be there. What is not similar is the profile in terms of toxicity, and I think this is important to discuss. A first aspect is the fact that indeed the type of treatment is different. So patients receive either IV treatment or oral therapy. So this might play a role in terms of patients' preferences if the outcomes in terms of benefit are the same or similar. And especially for tebentafusp, the treatment needs to be given as inpatient, so hospitalization in the first 3 cycles, because of the potential adverse events that we see that need immediate treatment. And after that, if the patients do not have significant adverse events, we can treat them as outpatients, but again, every week. So this might also play a role in terms of patients' preferences if the outcomes in terms of survival are the same. And this is exactly what I say here. The long-term toxicity from the target therapy is probably different from the immunotherapy, as we saw in other target and immunotherapies previously. And the benefit that we see with this combination seems to be the same regardless of treatment line. So either the patients receiving in first line or patients that already had received the first line. And also regarding the HLA subtype, as I said before, this is an aspect that it's necessary to clarify before giving a tebentafusp treatment. But the numbers are quite low, so we definitely need more follow-up and more patients treated before we have further or definitive conclusions. The clinical efficacy obviously needs further confirmation. The safety profile, I think it's quite manageable, but again, this depends on the type of adverse events that the patients are willing to have or to get managed. And the ctDNA reduction, as I said, it seems to be an important biomarker in other tumor entities, but we need to have more data in patients with uveal melanoma and other melanomas to see if it has the same impact and the same importance as we see in other solid tumors. And I pass now to Violeta.
Yeah. Yeah, well, thank you very much for this. It was very nice to hear that at ESMO, and you made a very nice presentation here. Results were received with a lot of enthusiasm in our groups, I would say, by everybody. And to be honest, I'm expecting now an accelerated approval rather than in this rare population, in this rare melanoma population, rather than a phase 3 trial. You made this interesting indirect comparison during ESMO with ipi/nivo and tebenta for HLA positive patients, and I find it quite useful. Researchers are always saying, yeah, we should not do that, but always we end up there because the HTA's bodies in the countries, they are doing actually this indirect comparison. So they are taking everything that's available in that country and they're comparing. So again, once again, we are expecting this comparison on the ground.
Yeah.
Yeah, so it's useful for the future implementation of darovasertib and crizotinib, daro and crizo,
it's easier.
are saying. Yeah, and especially in melanoma, where, as I said, the standard of care is very diverse in Europe. So you can find everything from dacarbazine to checkpoint inhibitors.
Mm-hmm.
So if we will move to a phase 3 trial, once again, what you will expect the comparison will be if we will move for a phase 3 trial. I know that it's difficult to project that in the future, but it's so important. Your opinion, not something that will happen, but your opinion.
Yeah, so it's a very difficult question, but I think it needs to be done indeed. So besides the tebentafusp, there is really not an approval for other therapies for uveal melanoma. So we do other immune checkpoint inhibitors based on the results that we have for cutaneous melanoma, but an approval for uveal melanoma per se is just for tebentafusp. And this is a treatment that is actually HLA restricted. So if you don't have the let's say, the correct HLA subtype, you will not respond to this treatment. So it will be difficult to have a trial that actually compares daro-crizo with tebentafusp. I don't think that this will happen, but maybe I'm wrong. On the other side, it will need a very high number of patients to be screened so that we have enough patients to be treated with daro-crizo, and that can be directly compared with tebentafusp. So I'm not sure if this will happen or not.
And there are different mechanisms of action. So actually, you compare target therapy. And
exactly.
with immunotherapy.
Absolutely, you are absolutely correct. So the comparison that I did, it's obviously indirect, and as you said, we need to do it because when we have a patient that is in front of us, we need to try to decide what is the better option for him. So we end up doing these comparisons if this is not something that we should do. So I think the ideal comparator. So in the tebentafusp, the comparator arm was physician's choice.
Yeah.
So it might be that it will end up like this as a physician's choice. And here you can choose a PD-1 mono or combined immunotherapy, or even tebentafusp if this is available and the patient has the right HLA subtype. I think it might introduce a little bit to diversity in the comparator arm, so that we might not be able to have a lot of, or can perform a lot of conclusions if we have this diversity of treatment arms. Let's say the fairer comparator, I would say it's ipi/nivo in this case, so that we have an immunotherapy, that we have a safety profile that is known. We already have data from smaller trials in first and second line, so we can also see if the patients have the same benefit as we saw before. And I think in the real life, for patients that have don't have this HLA subtype that is needed for tebentafusp, ipi/nivo will be the choice or the therapy that we'll offer if available in the country. So I think a fair comparator would be ipi/nivo in this case. And then you need to wait to see if there is, because for target therapy and immunotherapy, the comparison or the initial data might somehow favor the target therapy, because the response rate is normally higher with the target therapy, and the immunotherapy takes a little bit longer. So we probably need some time to actually see if this benefit in terms of response rate, or maybe, I don't know if there will be a difference or not, but if this difference in terms of response rate actually translates into survival benefit, because I think this is what the patients want to have. And if not, and I think this is something that you probably discuss as well, how will be the access to the further treatment lines if they don't benefit from the first one, right? Because you were discussing that as well for the previous study. the access to the treatments depends on the type of treatments that the patients had before. And in some cases, it becomes a little bit difficult if they already had ipi-nivo and so on. So
absolutely, absolutely, and thanks for that. It's always good to think and to project the future when you design these clinical trials, and it's not always the case. That's why I'm asking, and I'm trying to not to test your knowledge, but to raise awareness, to raise awareness about this aspect, because very often when we design the clinical trials and we as patient advocacy group, we are called to revise this, we just noticed that the researchers or the company didn't think further than that clinical trial and the approval on the European market or US and so on. But then is coming the approval in the country where the situation is completely different. So I think it's interesting to remind patients that this is the first generation of PKC inhibitors that did work, because first generation didn't work, and was a big disappointment. I don't remember the name of that, but was a response rate that was really low. And also we had other inhibitors like cetuximab was also disappointment in uveal melanoma. So this is the first time. And actually what we notice is that they use a more selective form of protein kinases in this respect, which is darovasertib, and they made a synergy with crizotinib. Now, I think as patient advocates, but most important as researcher, is not to give up on this line, because it's really now is proved to be a bit of success there, quite substantial, I would say. Even the population is small, and to keep an eye on the field of targeted therapy in uveal melanoma, and probably is a dream, but is a realistic one, looking to cutaneous, to arrive to those clinical trials and research that are alternating and sequencing the targeted therapy with immunotherapy like tebentafusp in certain groups of patients, and to obtain this long-term survival that we dream about. Now I wanted to ask you something else, actually. What is the point and for the clinical practice of measuring ctDNA as biomarker in this setting? Because we speak about the metastatic desperate populations. So as we saw in other clinical trials, you use ctDNA as a biomarker to measure the efficacy of a treatment or to select those patients more likely to respond to the treatment. So what we are doing in clinical practice with the ctDNA, we hope to validate it and to use it in clinical practice for what at the end.
So that's a very important point. And I just want to go back to your other comment on not giving up on the research, because you know that the translational research and the preclinical research are so important. And sometimes we have failures and we just put a molecule or the work aside. And in some cases, we just need to be a little bit more, insist a little bit more on what we are doing. And sometimes we have let's say good surprises, but it's difficult to keep yourself motivated when the results are not that good, right? So but it was very important that you mentioned that. Regarding the ctDNA, and this is a very important point, and we discussed this also during ESMO, and the issue with the ctDNA, I would say, across tumors, is that there is not really a validation or harmonization on how we measure this ctDNA response and ctDNA clearance. So the way that it's done in the different clinical trials and the different tumor entities, it's a little bit different. So it makes it difficult to compare if we are just based on the ctDNA reduction, compare different treatment options, right? So we need to have more than that. what for stage 4, I think it's important, or for advanced stages, I think it's still important to do it, because it kind of gives you, let's say, an indirect or a direct measure of the tumor burden in a way. So and also the type of response that the treatment can provide to your patients. For monitoring, we are also using it in our clinical practice. Mostly in stage 3, but also in stage 4, but it's not, let's say, it's not used, at least not, still not now, to make treatment decisions. It's just kind of an investigation tool. We can add that to our treatment decision algorithm, but we do not make decisions based on ctDNA alone. There are ongoing trials evaluating this. And one of the aspects that it's important to mention is that not all tumors shed, so to say, ctDNA. So the fact that you don't see exactly. So the fact that you don't see, or you cannot measure ctDNA, doesn't mean that the tumor is completely gone. So we also discussed these patterns of response. So patients that are permanently negative, patients that were negative and then became positive, or patients that were positive and then became negative. And an important point, and I think this is maybe what you were going, is this longitudinal evaluation. So if you just have ctDNA evaluation in one time point, you really cannot make so you cannot say anything about this particular patient. So you need to see how the ctDNA evolves along the time. And if you can identify a pattern, and if in this case, as I said, the tumor is producing ctDNA, then you might be able to use it as a biomarker. And specifically in the advanced setting, but also in the metastatic setting, for patients that do not respond based on the ctDNA analysis, they might be candidates for intensification of the treatment, so that we can offer them earlier a potential new treatment, or adding something in terms of treatment. And for those that respond, maybe it will be okay to de-escalate the treatment and to reduce either the intensity or to the duration of the treatment. So I think in the future we'll be able to use it with more certainty on what we are doing. Right now, it's one of the aspects that we use for treatment decisions, definitely, but it's not only based on that.
Oh, absolutely, and I asked that because we saw what happened in the adjuvant setting, where ctDNA is really useful because you don't have a tumor to measure and to scan. But for metastatic setting, I'm very happy that you said that, and I think the most important thing for us will be to stop earlier the treatment if it's not working, and then to start the second line. Let's hope that in uveal we will have enough choices. And to have, let's say, early detection of the progression and to treat it in a timely manner.
Yeah.
So this will be indeed something that is valuable for us, at least in the metastatic advanced setting, inoperable, irresectable setting of uveal melanoma, or in general cutaneous melanoma.
Yeah, I agree.
Yeah. I think thank you very much for mentioning that, and I think we should go to the third presentation.
Okay.
Avelumab and cetuximab is now.
Yeah. So now we are changing a little bit of gears. We are looking into unresectable cutaneous squamous cell carcinoma. So this is another skin tumor that is quite, or that we see more frequently than we see melanoma, for sure. But the patients that actually go and progress into advanced stagings are a little bit so lower numbers. And because of that, the type of treatment options that are available are not, let's say, as many as we have for melanoma. And the investigation in this advanced setting, it's also not so as active as we saw in melanoma. On one side, because this advanced entity, it's not as frequent on one side. On the other side, because this normally happens in older patients that have some comorbidities as well, so it's more difficult to include them in clinical trials, and also to provide them treatment that doesn't add toxicity that then it's not possible to treat because of the other comorbidities that the patients already have. So this treatment is the combination, as you said, avelumab and cetuximab. And I think it's an interesting study, and I would like to call your attention to the fact that this is an IIT, so it's an investigator initiative trial. So these are the trials that try to answer the questions that are clinical relevant, and for whom sometimes there is not a lot of interest outside the academia. So here, basically, the investigators looked into the clinical activity of avelumab, which is an immune checkpoint therapy, and cetuximab, which is an EGFR inhibitor, in patients that had unresectable, so patients that were not surgical resectable, stage 3 or stage 4 cutaneous squamous cell carcinoma. There are some data that show that both these immune checkpoint inhibitors and EGFR inhibitors are effective in patients with squamous cell carcinoma, but still we need better treatment options, especially for those that do not respond to PD-1 inhibitors. And here we have this anti-PD-L1 inhibitor, avelumab, and a combination with EGFR inhibitor. So 54 patients were included, which I must say it's quite impressive for an IIT and for this setting of patients with cutaneous squamous cell carcinoma. And then they were treated with avelumab and cetuximab for up to 1 year. And the analysis that has been presented during ESMO were for patients that received at least one treatment, or for those that received more than 12 weeks of treatment, which is approximately 3 months. And as you can see, so approximately 50% of or more than 50% received more than 12 weeks, but there were some patients that actually just received one study treatment. So these are the results, and also the different types of the different population that was evaluated. As you can see, we have a high older population, so to say, compared to other studies where we include patients with melanoma. So these are typically older patients. We also have a very interesting percentage, let's say very high percentage of patients that have anogenital squamous cell carcinoma, which is definitely not only a rare entity, but also a very difficult to treat, not only locally because of the need to keep the function, but also because from a surgical point of view, it's definitely not easy to treat. Patients that had already received previous therapy, so patients that per se were already patients with worse outcome. And but you can see that the median progression-free survival, so 50% of the patients that were alive at 8.4 or without progression at 8.4 months, and for those that received 12 months of treatment, 12 weeks of treatment, which is this population of 37 patients, 9.2. So I would say that it's very interesting outcome, especially in this very difficult to treat population. The median overall survival for patients that actually managed to receive more than 3 months of treatment, it's 25.4 months, so more than 2 years, which again, I would say that it's a very interesting outcome for this difficult to treat population. The toxicity, of course, exists, especially with the combination, but I would say that the toxicity, we had some patients also treated in our center, the toxicity was, I would say, manageable. Obviously, for the patients, the importance that they have and that they give to the toxicity, it's different from, sometimes different from the importance that we give as doctors, but still, I think it's a pretty reasonable toxicity profile compared to other treatments, such as, for example, chemotherapy. So I think we can conclude and say that indeed this is a potential new treatment option for patients with advanced SCC, and especially for these two subgroups of patients, so patients with anogenital cutaneous SCC and those that already received PD-1 monotherapy. Changing to anti-PD-L1 and adding an EGFR inhibitor might be a solution in the future for this subgroup of patients indeed.
Very good news for patients with the advanced squamous carcinoma. So we are on a good trend, I would say. I don't know, we are active more in melanoma, but in the last time we had a lot of patients with squamous carcinoma joining our national groups. Mm-hmm. And I think especially in the Eastern European countries, we met this phenomenon, let's say. The main challenge is that they are still guided to the surgery, and this is pity. Even the disease is at the limit of being operated. So our advice, and I take advantage of this discussion, it's usually to encourage patients to see an oncologist in the specialist centers and tumor board to decide the correct course of the therapy. Usually this, as we saw, are older people, especially men with quite advanced disease, and probably a population that is also not very proactive and needs more support from everybody, and attention from all of us. The efficacy, I cannot comment a lot of that because it was quite impressive, taking in consideration that it's an elderly group, 70 years old people we saw. Median survival of 17 and 25 months with no difference in efficacy for the stage 3 and stage 4. So both of groups were included, if I understood well. So these were people treated with chemotherapy and immunotherapy in the same previous. And yes, and just to inform patients that avelumab and cetuximab are both immunotherapy, if I don't mistake, and given by perfusion. And
so EGFR, it's a target therapy. It's an EGFR.
Is a target therapy or an immunotherapy?
So cetuximab, it's an anti-EGFR inhibitor, so it's a target therapy, so to say. It's an it has let's say. I would say that it's considered a target therapy, but it's
okay. So
it's not. But it's an IV, so it's directed.
Both of them are IV.
Yes, they are both IV, and it's an EGFR inhibitor. So it's I would say that I'm not sure if we can consider that as a strict target therapy, but I would say that it's different from.
I was looking to the MAB at the end, you know, this termination in MAB.
Yeah. And avelumab, it's a immune checkpoint inhibitor. So I would say they are not. I would not call it like it's an antibody. So it's an antibody. EGFR, it's an antibody definitely. And I would make a difference between avelumab and cetuximab because it's not an immune checkpoint inhibitor. That was my point, right? So
Okay, good, very good point. And I think it's important to know this, let's say, details which are at the end translated in the way in the administration schemes for patients. Now I have this curiosity, not only for me, but also for the patients that are coming to our groups. If you can say a little bit more about what is now available in metastatic setting for squamous carcinoma patients that are not resectable. Yeah. So what other therapy are there?
Yeah, so I would like to highlight what you said before in the very beginning, that these patients should be discussed in a multidisciplinary tumor board, especially because, as you said, in some cases there are very heroic resections and surgical resections that are also mutilating resections. So it's really not possible for us to then So now again, so I would like to emphasize what you said in the beginning, because it's very important that we discuss these patients in a multidisciplinary tumor board where oncologists, radiotherapists, but also surgeons from the different specialties, so head and neck, general surgeons, neurosurgeons in some cases, that actually can assess the patient as a whole in terms of the comorbidities that they already have, but also let's say the extent of the surgery, because in some cases we see very heroic surgical resections that in some cases are not complete resections, so the patients are not tumor-free, and it's not what we call an R0 resection, that the totality of the tumor is operated, and then we need to provide them obviously some kind of systemic treatment. But maybe similar to melanoma, it would make more sense, and we have some data in that direction, that maybe with the tumor in place, with what we call neoadjuvant treatment, the outcomes would be better. And in some cases, indeed, the surgery is so mutilating, and the complications after the surgery are so much that it's a question whether there is really a benefit of in terms of providing this surgery to the patient. So a multidisciplinary discussion is obviously necessary. There is immunotherapy approved for patients with a resectable cutaneous squamous cell carcinoma. And in some countries, might be that indeed immunotherapy, it's not available to all, so they need to receive chemotherapy, but immunotherapy in first line is considered the standard of care for patients with advanced cutaneous squamous cell carcinoma. And in some cases, as in a neoadjuvant concept, might be that the patients will need surgery afterwards, or could indeed benefit from surgery afterwards. But if they are not operable, or if the surgery is very mutilating and there is not a clear, or it's not clear if we can completely resect the totality of the tumor, systemic treatments should be offered. And in case the patients do not want that, or it's not possible because of the comorbidities, radiotherapy could also be an alternative to mutilating surgery. So I think what you said, it's very, very important. Patients should be aware that they should receive not just one opinion. Exactly. And they should try to find a center where a multidisciplinary tumor board discusses these cases, and before they decide for the surgery, which is a therapeutic option in some cases, they should hear what else they could be offered in terms of systemic treatment and other local treatments.
Thank you, Teresa. And I think I'm very happy that you mentioned the neoadjuvant setting. If I remember well, last ESMO was something about cemiplimab in the neoadjuvant setting. Was a retrospective trial, but really good data. So let's hope that this is going somewhere for the utilization. They were actually from MD Anderson, I think, was the study, but they were actually utilizing that setting, the neoadjuvant setting for or maybe was for a squamous carcinoma in real life. So and then they got retrospectively the data, and was quite encouraging. So maybe if we will be more let's say not so restricted by cost in Europe, maybe we will be there as well soon. Okay, it's a hope.
I think so. If we try to translate the data that we see in melanoma and other tumor entities, might be that neoadjuvant is really an option in the future. And as I said, in cases where it's not operable, or it's not clear that the patients will be tumor-free after the surgery, I think it's acceptable to discuss systemic treatment up front. And not with the neoadjuvant concept, but in the end it works like this. And maybe in the future, if the patients need a surgery, still need a surgery later on in the course of the diseases, maybe the surgery will be easier, and the defect or the complications will be lower or none.
Yeah, to use it like an induction, like breast cancer is doing. Like you reduce the volume of the tumor, and then you can operate safer. Yeah, exactly. It's very, very good point.
Yeah.
I think it's a lot to speak about, but we have a limited time.
Yeah.
Now we have study number 4 in Pembra trial with dabrafenib and pembro. If you want, we can go further.
So this is another trial also for melanoma, where we can see the outcomes of what it's called a triple combination therapy. So these are the 5-year survival, and the interesting part of this trial, or the interesting aspect of this trial, is this intermittent target therapy that was given in combination with anti-PD-1. So basically what was tested, it was this short term of target therapy of dabrafenib and trametinib, and patients received also pembrolizumab. They had a stage 4 melanoma, and the idea was to see if there were better outcomes in terms of long-term benefit, but also in terms of lower adverse events associated with the triple combination, because for those that are not so familiar, the triple combination has been tested in previous trials with conflicting results in terms of clinical benefit, but what we saw across the trials was an increased toxicity from the triple combination. So it's one of the aspects that needed to be we need to look into more detail. And so the study was a little bit so the design it's not straightforward as we are used to other trials, but basically the patients were treated, they were treatment naive, so they didn't receive any previous treatment for stage 4 melanoma. And obviously, because this was a target therapy it's a target therapy with a BRAF MEK inhibitor, the patients had to have BRAF mutation. So patients without this BRAF mutation could not be included in the trial and cannot receive target therapy. So they would be randomized to receiving pembrolizumab monotherapy, to receive pembrolizumab plus darovasertib and trametinib in an intermittent, so twice or so we did these different schemas for twice 1 week, then for 2 weeks, or for 6 weeks. So the idea was to test these different schemas, but in all of these cohorts, the patients received the triple combination. And then after 12 weeks or after 3 months, the patient continued with pembrolizumab monotherapy for a maximum of 2 years. So the authors presented data on progression-free survival and overall survival. And also, I think a very important aspect that we don't see much in the trials, which is the type of treatment that the patients received afterwards. Because as you can imagine, the total benefit in terms of overall survival for a treatment also needs to take into account if the patients had access to the best treatment option, if they didn't benefit from the treatment that were being tested in the trial. So this is an important aspect that sometimes is missing in the trial reports. And you can appreciate that the 5-year overall survival was similar across the different cohorts that received the target therapy, and higher than the patients that received PD-1 monotherapy alone. So the cohort 2, I will just go back. This is the ones that received just 1 week treatment. And then for those that received 2 weeks or 6 weeks, the outcome is pretty similar in terms of overall survival, although the progression-free survival, it's not exactly the same in the different cohorts. So this study with this 5-year survival data shows that indeed this intermittent short-term duration of target therapy can add in terms of survival benefit for patients that receive PD-1 monotherapy and have this BRAF mutation. And this is better than just receiving PD-1 mono alone, at least in this small cohort of patients that is with 32 patients that were presented.
So thank you, Teresa. Yeah, this was fascinating. This was a fascinating study and interesting because, as you said, we saw in the past that triple therapy had higher toxicity when given continuously. And the efficacy was not so impressive. Actually, was disappointed what we saw in the trial with spartalizumab and dabrafenib and trametinib in combi-I. And the idea to combine immunotherapy with target therapy came from both translational studies, as you know, but also from the frustration. And I think frustration was from both of parts, that we cannot have all the benefits we want in one shot, of products. And so then we know that target therapy, just for patients to remember, have a response rate over 70%, and the progression-free survival of only 19% after 5 years. In comparison, immunotherapy present lower responses rate, about 40–50%, but higher progression-free survival at 5 years. And if we remember, the overall survival of combination ipi-nivo at 7.5 years, it's 55%. So half of the patients benefit from immunotherapy, but in the same time, the response rates are not so high as we would like to see. Okay, after the disappointment with spartalizumab triplet, this was in 2020. I remember that it was COVID time and we had this online virtual ESMO. And I remember that were some speakers saying that the addition of anti-PD-1 to BRAF/MEK inhibition is not associated with better outcomes for patients and should not be studied further in melanoma. So, but even in that time, I was suggesting to adjust the doses and to try different schemes in order to reduce the toxicity and to keep these high response rates in of target therapy, and somehow to make immunotherapy to take over during time. And that's why I really appreciate this, and we selected this trial in Pembra, which ran at NKI Netherlands, because it's original as idea. I mean, clinical results, I will not say that tomorrow and we know will be translated in the practice. But I think the most important part here, and what impressed us, was the translational part, because it was, I think, 2012 or 2014 when the translational studies show that you can have an increase in the T cells or interferon gamma expression or PDL if you add target therapy at a certain time to immunotherapy. So some interesting aspects that are not mentioned in the presentation are at ESMO, but are in the paper of the researchers that was published in the same time in October last month, is that they saw this time in this study an increase in immune infiltrate after the addition of target therapy, T cell infiltration and interferon gamma expression. So these are just, let's say, sparkles that could fire the immune system in order to induce durable responses. They also notice rapid responses of Pembro, which was surprising for them. So in the first 6 weeks, so this a little bit spoiled the design of the trial because they didn't expect this rapid responses of Pembro. Because these patients probably had a good performance status, but that means that not all the patients included in the trial could benefit. I mean, they don't need the addition of target therapy. Some patients were responding very fast in 6 weeks, which is unusually for what we know from monotherapy. But this is good news. In the actual setting, there are patients, probably good performance status, treated better in advance. They have rapid responses. And the most interesting part, and I will finish with that, is that the response to the treatment was seen early via ctDNA clearance in the bloodstream just before being documented on the scans. So ctDNA has the potential to separate patients who need target therapy additions from those who doesn't need a target therapy addition. And this is another interesting point that I think we can go further with it. What is your opinion about this and about this part? With the biomarker separating people who need or not of this addition of target therapy.
So these are very, very interesting points, Violeta. Thanks for pointing this out. And I think you just went through the point, which is the need that we have to kind of identify the patients that might need an extra push, so to say, to respond to the treatment, and those that don't need it. So we don't need to add them potential toxicity to the treatment that they are already receiving. Again, this is like let's say an idea from an investigator that has been translated into a clinical trial, so similar to what we saw before. These are the academic trials that are trying to answer the questions that might not be so interesting outside the academia world. And the biomarkers that we need, and you mentioned the ctDNA that actually can give us maybe some insights before we see it in the radiological evaluations, because this is what we do in the clinical trial, in the clinical life. It's very important. And as we discussed before for ctDNA in the uveal melanoma, I think not only this, but other biomarkers that are being that we are trying to look now, like the interferon gamma signature and so on. So these are aspects that we are investigating now, and I think in the future will help us to better select the patients and actually on treatment or shortly after starting the treatment will allow us to make decisions in terms of should we continue, we don't need to continue, should we intensify, should we de-intensify treatment. So this is where you were discussing and the points that you were pointing out, and I totally agree that we need to go more into this direction and more into this personalized medicine based on the biomarkers. And I think we are moving there, especially in the neoadjuvant setting. I think we are moving there in that direction, and I hope that for the advanced setting we can also do that. But it's definitely a field that we need more investigation, and I think the IITs in that area are probably the solution in the near future.
Absolutely right. And well, we would like to have one biomarker that is working and not a box full of biomarkers that you cannot apply in clinical practice. But this is a dream of everybody. So let's hope that we will get there.
That's true.
Yeah. Shall we go further?
Yes, for the next one.
Yeah.
So the next one, it's a very, very important trial, and I would say a very brave one from the patients that have been included in the trial and accepted to be included in the trial on one side. And I think that's the most important side, in my opinion. On the other side, also from the investigators, again, initiated an IIT trial, or at least an idea. It came from academia that to actually perform this treatment in these patients that have such a bad prognosis when they are diagnosed with leptomeningeal disease. And just for those that are not very familiar what it is, this is the disease of this, let's say, this membrane that involves the brain, and this is for patients that have metastatic disease in that area. And we know that these are patients with a very bad prognosis. And the idea from the background from this study was, if we inject and if we apply directly treatment in this localization, do we have better outcomes? And combined with intravenous therapy, do we have better outcomes than with intravenous therapy alone? So this concept has been tested before, with the intrathecal therapy has been tested before in other solid tumors, especially in breast cancer, but with chemotherapy, so not with immunotherapy. And the idea of this trial was actually to look whether this was safe. First of all, if we could inject intrathecal nivo for patients with leptomeningeal disease, and if we could combine this with what we already give, which is intravenous therapy with nivo. So the investigators looked into that exactly. The primary objective was, as I said, safety, and the secondary objective was overall survival. And you can appreciate that this is a very difficult to run trial, not only for the type of the patients that are included in the trial, because but also because of let's say the multidisciplinary environment that you need to have, the access to a neurosurgeon that can have a Ommaya reservoir implanted, which is kind of a reservoir that you have implanted in the leptomeningeal cavity, so to say, so that you can apply the treatment locally. So it's not in all centers that you can do it. And then the type of the patients that are patients that in some cases are not very fit. And if we are looking into evaluate the safety of a combination in a trial, we need to have, let's say, fitter patients, so that you are sure that you are not adding only toxicity to this population of patients as well. So the number of patients that were treated was not as high as we would like to have, for sure. But I think, and they tested also some different combinations and doses of some different doses of nivo. But you can see, and this is highlighted here, that for whole patients, the median overall survival, this is in weeks, and I would like to mention that these are not years, unfortunately, also not months. This is in weeks, but still, let's say the median overall survival for this type of population is quite encouraging. And I would say that most interesting even is the fact that they could show that giving intrathecal nivo was not adding any toxicity to these patients. So they could combine this with intravenous therapy as well. So this is what I just wrote. There were no differences in terms of overall survival, but there were no unexpected toxicities. And I think one of the most important aspects, and we have been discussing this also in other clinical trials as well, is the translational data that we get from the lumbar punctions and the samples that we are getting from these trials, and that we can continue to do translational research on one side, but also on the other side to show that even these patients with very difficult to treat disease and some kind of not so accessible disease, they still can benefit, and they still can be treated with other, or they still can be included in clinical trials, and we should not give up on treating these patients that most of the times, if not all of the times, are excluded from other clinical trials.
No, thank you, Teresa. I think it's clear why we choose this abstract, and median overall survival of 7.5 weeks, with the overall survival of 35%. It's looking low, but it's not something to ignore for patients with these conditions. And just for a bit of background, and for patients, most systemic treatments, so the treatments that are given for the whole body, are not penetrating into the cerebrospinal fluid. And this is a fluid protecting the brain and the spinal cord and present in the brain ventricles. So not easy to be reached by medication, apparently, from what we see from other studies. And as we hear, the leptomeningeal metastases have higher frequency in patients with melanoma, and unfortunately even higher frequency in case the patients have a BRAF mutation in their tumors.
Mm-hmm.
Something else that I find crucial for us in the context of and is in the context of early detection of brain metastasis, because nobody wants to arrive to the point to have an intrathecal infusion on avelumab. So I think we should pay more attention to the early detection of brain metastasis, and we have, I would say, a full advocacy movement about that, especially for patients with high risk. And here is another story, how to define high-risk patients in the context of most likely to get brain metastasis. But this is a devastating condition. We saw in this presentation that LMD affects young people with a median age of 50 when diagnosed. Patients need to keep in mind, and this is for patients, that both MRI and cytopathology are the ways to diagnose LMD, and it's important to know that sometimes MRI can look normal, but leptomeningeal disease is still present. So the cytopathology is the one that brings clarification, and they should advocate for that to be sure that this is the case. I have two questions for you. And one is, what are the circumstances that should prompt clinicians and patients to investigate the presence of LMD? Kind of early indication for LMD, and even early symptoms that patients could recognize themselves at home. Because usually patients are a bit confused, but also clinicians, about the side effects of the therapies in the metastatic setting. And what we notice is the LMD are too late reported to the clinicians. So this is the first one.
So I think so. Thank you very much. This is very important from a practical point of view, because we are treating patients with stage 4. There is obviously a risk that they have metastatic disease in other localizations, and as you said, sometimes it's difficult to define what is toxicity and what is disease. So it's not clinically, it's not sometimes very easy. I find what you said very important in terms of following up with the right radiological evaluation. We know that in some countries, some patients do not have access to MRI, and this is quite worrying, because as you know, in a CT, it's very difficult to have all this information, not only for leptomeningeal disease but also for brain metastases. So it's if there is a suspicious of brain metastasis, the patient should receive an MRI and not a CT. And if they have a CT scan with brain metastasis, an MRI should follow, because this changes in some cases the type of treatment that we can provide to them based on the localization, but most of the times on the number of brain metastases that are seen then in the MRI. So my advice for the patients that are receiving immunotherapy is that for any kind of new symptoms that they have that is related to the neurological part, let's say headache, differences in terms of sensibility, or some movement problems, whatever that we normally associate with something that is related in the central nervous system, they should report this. It might be that this is indeed associated with the immunotherapy. So we know that there are some immune-related adverse events that occur under immune checkpoint inhibitors that affect the central nervous system. So definitely this is one of the possibilities. But on the other hand, as you said, possibility of LMD it also exists, and this should be excluded. And as you said very, very well, patients that have a normal MRI but still have symptoms and do not improve in some cases with corticotherapy, which is what we give normally for patients with suspected adverse events. Upfront, if there is a suspicious of any of these aspects, lumbar puncture should be performed. In some cases, the lumbar puncture, it's not completely definitive in terms of giving our diagnosis, but it adds to the information that we have from the MRI. So indeed, in our case, we are lucky because we have a multidisciplinary team that actually takes care of these patients, and we have an extremely good connection with the neuro-oncology, and they see our patients and they make sure that all the diagnoses are performed. But in cases or countries where this is not the case and it's not a rule, the patient should actively ask whether they should receive or whether it is needed to do a lumbar puncture or not, based on the assessment that the clinician did and the results from the MRI.
And thank you very much for that. I fully agree with you, and I am a bit jealous that you have everything there. As you know, I am coming from Eastern European countries.
Yeah.
I'm living in Netherlands, but I still have the memories that sometimes is not working. And I'm working with patients, so it's not only memories, it's what sometimes is happening in the practice at the present.
Absolutely.
Yeah. So what I wanted to ask you now, from the technical point of view, how difficult is to do that? You need a specialized to do intrathecal administration of immunotherapy. You need a specialized team. What is the challenges here? What are the challenges?
So no, I don't think that you need a specialized team. You can, as an oncologist, administer this therapy. I did it myself when I was a resident, and in patients with breast cancer, and we applied chemotherapy, not immunotherapy.
Mm-hmm.
The amount of treatment that you can give is obviously, in terms of volume, it's obviously reduced, because you cannot increase the volume of the too much of the volume that exists in the leptomeningeal space, so to say. But in terms of technique, it's not that difficult. So you need to learn it, of course, if you never did it before. But with the Omeyer reservoir, technically, it's quite easy, I would say. Yes.
Oh, this is great. Great to hear.
Yeah.
Thank you for that. So if you agree, we can move now to our last presentation, which is the second big trial.
Yeah, so we move to the next one, where we also chose a trial, or at least a part of the trial, that evaluated the outcomes of patients with brain metastases. And I think, as you said, this is quite important, because this is a population that has still is excluded from clinical trials. In this particular trial, they were not looking into patients with brain metastases, but they looked into what happens and if the treatment that was given actually decreases or increases the time, so to say, increases the time until the patients have brain metastases, if they develop brain metastases at all. This is an interesting trial. Again, something that comes from an academic world. And in this trial, it was actually tested whether for patients with BRAF mutation, whether we should start with immunotherapy, with target therapy, or if we should give a short course of target therapy and then change to immunotherapy. So this is the question that we have in our daily practice. If we have a patient with BRAF mutation, should we treat them with target therapy, or should we treat them with immune checkpoint inhibitors upfront? And the data that has been presented before shows that for patients with BRAF mutation, and not only from this trial, but from another trial, should in principle be treated with immunotherapy upfront. But in this specific trial, the sandwich approach shows that for patients that have a short course of target therapy upfront and then switch to immunotherapy, they seem to have a similar prognosis as those that received target therapy, immunotherapy upfront. And what they looked into, this specific aspect, was the brain metastasis-free survival, which means the time between initiation of treatment and the diagnosis of brain metastasis. So this is let's say not a metrics that we use much in the daily practice, but it's important because if patients develop brain metastasis, they obviously have a worse prognosis, and we need to see if with these approaches that they have been testing here, actually this time increases, and in some cases may not even exist, may not even happen, so to say. So these are let's say the number of patients that have been included in each arm that I already said. Either the patient started with target therapy, with immunotherapy, or with the sandwich approach. And the median follow-up so far, it's 43 months. So what the investigators showed is that for patients in the different arms, how many patients had developed brain metastases during the first-line treatment, and how many had then intracranial progression during the study. And you can appreciate that the patients that were treated in arm A, so target therapy upfront, had a high, so there was a higher number of patients that developed brain metastases compared to the other two arms, the first one immunotherapy upfront and the other one with the sandwich approach. And then another point that we were discussing also today in this presentation was the biomarkers question. So as we discussed for the other trials as well, the issue is, can we identify earlier patients that are not benefiting from the treatment, or patients that are benefiting from the treatment and we don't need to do anything else? And this is what the authors tried to do here with two biomarkers, or two measurements. The first one was the TMB, tumor mutational burden, that we know high tumor burden is associated with better outcomes to immune checkpoint inhibitors in a majority of the tumor entities. And then the JAK mutations, that is we know that the mutations in this gene are associated with worse outcome. Yes. So the results are, I mean, the number of patients for which we have this data, it's not very high. And I would say that there is we need to interpret this data with some caution, but I think these are very important data that go into the direction showing that even for patients with BRAF mutation that have even for patients with BRAF mutation and starting with immunotherapy, still the benefit is not only in terms of progression-free survival, but there seems to be a benefit in terms of this in brain metastasis-free survival, which we know is something that not only affects the quality of life of the patients, but also obviously the survival in the long term. So what the authors showed is that for patients that received either this short course of target therapy up front and then immunotherapy, or immunotherapy up front, they have a longer brain metastasis-free survival compared to those that start with target therapy. And for patients that have a TMB high or a JAK mutation, they also seem to have a better brain metastasis-free survival than those that do not have these two or that are TMB low or JAK wild type. So I think we need to move more into this direction, or we need more data into this direction. But I think these are very, let's say, promising data or promising aspects on the fact that the investigators are looking more and more into this direction and trying to provide the patients with this information, but also the other investigators that are investigating in the same area or in the same field, so that we can adjust also our investigation plans, but also look into what else can we see in our data. And the report of this data sometimes is missing in some trials, and I think this is fundamental for us to not only to interpret the data that is being presented, but also to move forward other areas of investigation based on the data that we already have. Right? Otherwise, we are going to do the same mistake again and again, or we are looking into the same things again and again without the knowledge of what has been done before.
Yeah, absolutely. Absolutely agree with you. And for this was let's say a great trial, and not so much in the translational part. This is for the message and adding to the body of evidence that is now out there, showing that people who receive upfront immunotherapy do better than patients with the first line of target therapy. So my takeaway for the patient communities, I'm sorry to say that, but this is a good enough evidence. And I would take advantage of this to message patient advocates, especially in countries with more limitation in the protocols. Please raise awareness of the study. Mm-hmm. I mean, clinicians should look into these studies and then decide and discuss with patients what is the best course to follow. And also in the public talks and specialized meetings, because we, as a patient advocates, we have access to all kinds of meetings and tumor boards and committees. And this is not data to ignore. And this is happening for several years in a row that we hear these things. And we know that oral therapies are used sometimes out of commodity and by both clinicians and patients sometimes, because, okay, it's oral therapy, you give it. And I'm not saying that it's in Germany, but it's happening in the Eastern European countries, and especially with COVID, we saw this exaggeration. And honestly, it's not worth it, because one can give up years of life. Of course, many clinicians keep saying that second bit is only phase to study, but it is. I know. But data is supported at least by DREAMSEC, a prospective study, the COG study with data from real life that run in Germany, and it's not the same population. I do agree, but everything, like you said, is converting in the same direction. And the recent translational research done in Pembra, actually, it's showing that, okay, you can add a bit of target therapy, but don't go with all the course from the beginning. So there are more ideas and more information converging to the same. And then for the safety, because we do a lot of things in melanoma for safety, like for example, re-excision. Yeah, nobody has the proof in history that re-excision is bringing overall survival, but still we are doing that. So for the sake of safety of patients, and I agree with Georgina Long what she said. I very much like that she said that with target therapy you buy time. And we appreciate that. And it's valuable, but with immunotherapy, I would add, one can get cured, and this is even more appreciated, as you can imagine.
Yeah.
With target therapy is this good point that we saw also in Pembra, that you can add start an immune reaction only if added at a certain time, because it's not looking like if you add it wherever you want, is doing the same. It's looking that you should add it in a certain interval. I'm not sure about that, but they choose a certain interval based on something, probably translational research between week 6 and in Pembra. I mean, week 6 and 12, I remember the design of trial. So if you added the small amount in a certain time could do very, very, very good to the overall survival. But for us, it's everything is going to the direction to start with immunotherapy. And let's hope that indeed we will have a clarification once forever on this topic. Now I would like to ask you something. How the results of second beat fit in the actual treatment landscape, because people are now treated earlier with adjuvant and neoadjuvant therapies. So how we can apply this in the actual setting, in the present landscape of therapies?
Well, I think this will be, let's say, a difficult question to answer in the future, as you said, with more and more people being treated in the adjuvant setting, and considering that some patients indeed will need to have a second line, or will need to have treatment in the advanced setting because they didn't benefit from the adjuvant setting, or they benefited for some amount of time, but then they had a recurrence, or they had a metastatic disease. So it will be difficult to, I would say, to actually position or to identify what would be the best treatment option for patients that already received adjuvant treatment. There are some algorithms, and let's say the type of the treatment that you offer in the advanced setting is based not only on the type of treatment that you received in the adjuvant setting, but also if you had a recurrence under treatment, or if you had a recurrence after stopping the treatment, and how long after stopping the treatment. I think the intervals that we have so far are quite artificial, so there is not really
like 6 months, or to have 6 months.
Exactly. So the 6 months, I think this is a little bit artificial, and in some cases complicates our life to include patients in clinical trials, because if they had a progression in these 6 months, in some cases they are excluded from the clinical trials. On another hand, if they didn't progress in these 6 months, they are also excluded. So I think these 6 months, you need to come up with the time, I understand, but I think it's a little bit artificial. But still, the decisions are based a little bit on these timings and whether the patients progress under therapy or afterwards. Let's say if you want to translate the second big trial, and this is my opinion with no data to support that, then you could say that if the patients have received target therapy upfront or during the adjuvant setting, they would change to PD-1. If they progress very fast, or if they have just a very short course, you can try to translate what we see in the second bit with this very short time of target therapy and then changing to immunotherapy. In the end, I don't think that we will be able to make these changes in the abstract, because you will see the patients in front of you, and you need to have a decision on what you are going to offer to them. Let's say the experience that we have in terms of responses to second line in patients that already received first line are not coming, the majority are not coming from clinical trials, are coming from retrospective analysis, and you cannot really compare the different patients and the different treatments that are being given. But this will be a question that will come more and more. And if you want to translate the second bit data, probably I would say that if the patients didn't progress under immunotherapy, they would definitely benefit, or they could benefit from the combination therapy. And if they progressed under immunotherapy, I would say the benefit can still exist. So,
but Teresa, what are the patients that are not receiving actually today immunotherapy in adjuvant setting? So
what are the patients?
Who are the patients? So sorry, who are the patients that are not receiving immunotherapy in adjuvant setting? So because I suspect this one, if they are progressing, you know, that there will benefit of first-line immunotherapy, because so it's a naive population. In many countries, you don't have adjuvant therapy in stage 2 BC, and you don't have it in stage 3A for in some countries. So this is an uncovered population. And neoadjuvant didn't come yet, so it's used. It's very scattered. The use is off-label somehow.
So you would say your question is for these patients that didn't receive adjuvant treatment, if we should apply the second?
Yes, if these results are validated, would be this a population?
I agree. My short answer is yes. So I think because again these were treatment naive or for patients with treatment naive that are BRAF mutated, I think we should try to apply this as well. But as you mentioned, in some countries still, unfortunately, in some countries ipi/nivo is not available as first line for all patients with BRAF mutation on one side. And then on the second part, for patients with brain metastases, also I know that in some countries, or at least I've been said that in some countries, even for patients with brain metastases, ipi/nivo, sometimes it's not available, and depends on what the treatment that you received before. So for patients that are treatment naive, my short answer would be yes, we should try to treat them with combined immunotherapy, because the data that we have show that this is the best treatment or the best treatment option that we have so far.
Yeah, absolutely. And with the NIBIT trial was really clear that there is no way back. I mean, I hope that brought that evidence that was needed to treat patients with brain metastases with the ipi/nivo combination. So with this, I think is the moment to close our discussion. And Teresa, once again, for this interesting discussion. And it was a pleasure. It was a pleasure to have you here. And thanks everyone for listening.
Thank you so much for the invitation. It was really lovely to discuss with you, Violeta, and also thank you for your extremely well detailed insights also on the background. I think it was really a fabulous discussion. Thank you so much.
Thank you so much.